Welcome everyone to the Virtual Evolution for Women by Women conference. We're going to discuss lung cancer today, and I have with me a fantastic group of expert panelists who I will let introduce themselves. I am Shayma Kazmi. I am a thoracic medical oncologist, and I'm so excited to be here today. Dr. Das?
Hi, everyone. I'm Millie Das. I'm also a thoracic medical oncologist with practices both at the Stanford Cancer Center as well as the VA in Palo Alto, California.
Thank you. Dr. Gillaspie?
Hi, I'm Erin Gillaspie. I'm one of the thoracic surgeons and I practice at Vanderbilt University Medical Center.
Thank you. Dr. Keane?
Hi, I'm Katie Keane. I'm a thoracic radiation oncologist and I practice at Massachusetts General Hospital in Boston.
Well, fantastic. So happy to have you all. Just for the viewers, feel free to type in any questions during the chat function and we'll be happy to answer them after the conference is completed. So without further ado, we're going to get right into our cases. Our first case is an EGFR mutation positive early non-small cell lung cancer. So this is a 38-year-old non-smoking female. She presents with shortness of breath and cough and is found to have a 4-centimeter left upper lobe lung mass with associated left hilar lymphadenopathy. She has a bronchoscopy and an EBUS with a biopsy that shows an adenocarcinoma of lung origin. She's clinically staged to have a T2B N1 MX2B disease. PET scan and MRI brain do not show any disease outside of the thorax. She does undergo a robotic left upper lobectomy with lymph node dissection, and the final pathology is consistent with her clinical diagnosis with a 4.2 centimeter adenocarcinoma, 3.5 centimeter left hilar lymph node with extranodal extension and perineural invasion. Margins were negative. EGFR testing is positive for L858R mutation. No past medical history, and she's a school teacher. Again, no history of smoking, which is a red flag. No alcohol or drugs. She's married with 1 child. So the questions in this case that we really want to discuss, of course, is typically we would not necessarily be ordering EGFR testing in early non-small cell lung cancer patients, but given the recent ADAURA data, that's what I'll discuss in terms of adjuvant Osimertinib, whether it's pertinent for this patient case. We'll then talk about the surgical modalities, and Dr. Gillaspie will walk us through all of the new breakthroughs in surgeries and even diagnostic modalities. We'll discuss adjuvant chemotherapy that would be appropriate for this patient as possible role of adjuvant radiotherapy in this patient as well. And Dr. Das and Dr. Keane will walk us through those. So the background for the ADAURA trial, we know that 30% of patients with non-small cell lung cancer have resectable disease at diagnosis, and standard of care in early non-small cell lung cancer is surgery followed by adjuvant chemotherapy in stage 2 to 3A disease. Despite all of this, recurrence rates remain high at 30 to 70%. We know that Osimertinib is a 3rd generation EGFR TKI. It's approved for first-line setting in EGFR mutated metastatic non-small cell lung cancer, or in the second-line setting if there's an EGFR T790M mutation in those who've had first-line EGFR TKIs. And current unplanned interim analysis of phase 3 ADAURA data comparing adjuvant Osimertinib versus placebo is what I'll present today. And this was in patients with stage 1B to 3A EGFR mutated non-small cell lung cancer. So this was a study design, a very large international randomized double-blind phase 3 trial. There was data cut off for interim analysis, and what they decided to do is they enroll patients with 1B through 3A resected non-small cell patients, primary non-squamous non-small cell with EGFR exon 19 deletion or L858R mutation. And these patients were stratified either via stage 1B, 2, or 3A, and they either received Osimertinib 80 every day or a placebo. And this was for 3 years, primary endpoint being investigator-assessed disease-free survival. There are multiple secondary endpoints. In the interest of time, I'll run through this quickly. The baseline characteristics were very well balanced, 2/3 female, 2/3 non-smoker, 2/3 Asian, and really a third of 1B, 2, and 3A patients. They're almost half and half of the exon 19 versus L858R mutation. So this is really the slide of most interest Kaplan-Meier curve for disease-free survival in patients with stage 2 and 3A. And as you can see, you can drive a truck through these graphs. The hazard ratio is 0.17. It's staggering. So adjuvant Osimertinib, prolonged disease-free survival in stage 2 to 3A disease patients, and the P is super significant. And even if you include the stage 1B, that hazard ratio is 0.21. If you look at, the forest plot that really favors osimertinib, you really don't see any specific group that does not benefit. Certainly the stage 1B patients approach the center, although you can see that it is still statistically significant with a hazard ratio of 0.5 and the higher end confidence interval being 0.96. When you divide it by stages, again, stage 1B, the benefit is not as dramatic. However, there is still benefit in 1B. Stage 2 and 3A, the benefits is clearly staggering. Now, the overall survival data is very early. You only have 5% maturity so far, but it's looking, of course, to be favoring osimertinib with a hazard ratio of 0.4. And safety data, of course, there's safety concerns with osimertinib, though I would say that it's one of the best tolerated TKIs. The overall grade 3 or greater AEs at 20% of patients, though placebo had 14% of patients as well. Possibly causally related AEs, 90% of patients had it, but more than grade 3 is only 10%. So fairly well tolerated. Grade 1 and 2 ILD did occur in 3% of patients. So it's not completely without adverse effects, but overall fairly well tolerated. Adverse effects are related to the epithelial growth factor receptor in skin and the gut, diarrhea, paronychia, dry skin pruritus. Most of them, again, grades 1 and 2. So the conclusions with ADAURA is that really an 83% reduction in risk of recurrence or death with OC in stage 2 to 3A disease, and 79% in the overall population. So disease-free survival prolonged with OC across all subgroups, including those patients who received prior adjuvant chemotherapy. There were no new safety signals, and they really recommended that this should be standard of practice for patients stage 1B, 2 to 3A EGFR mutated non-small cell lung cancer following complete resection. So now I'll give this over to Dr. Das, and she will discuss really the standard of care as it comes to the first-line chemotherapy.
Thank you, Shayma. So I just wanted to share just a single slide with you just about the standard of care as far as adjuvant chemotherapy and adjuvant radiation for our patients with early stage resected lung cancer. So many of us follow the NCCN guidelines when it comes to treatment decisions, and the NCCN guidelines have recommended 4 cycles of cisplatin-based adjuvant chemotherapy for patients with resected stages 1B, 2A, 2B and 3A disease. There's an asterisk in front of 1B because there is some controversy about whether there's true benefit in these patients. It could be considered for patients with specifically with a tumor size greater than 4 centimeters or with other high risk features. And so I think it warrants a conversation with our patients. We see, of course, greater benefit for cisplatin-based adjuvant chemotherapy in patients with stages 2 and 3A disease. For patients with positive surgical margins, adjuvant radiation can be considered, and it's usually either sequential or concurrent. And generally, these patients are reviewed in a multidisciplinary setting at a tumor board with a discussion between the surgeon, the radiation oncologist, and the medical oncologist to really determine the optimal sequence. And I just wanted to point out that LACE meta-analysis, which many of us may be familiar with, pulled together a number of different early stage adjuvant trials and demonstrated a 5 to 10% survival benefit with chemotherapy at 5 years, with the most benefit again seen in patients with stages 2 and 3 disease.
All right, so I'm going to talk just a little bit about surgery. So we've seen really a minimally invasive revolution over the last 20 years in our field. And really the first series of advancements is in mediastinal staging. Traditional mediastinoscopy, which you can see pictured here, really served as the essential component of histological mediastinal lymph node staging for the better part of the last 70 years, having been introduced in 1954. And while it's undergone some technical modifications, the principles largely remain the same. As you can see here, we make a small incision at the base of the neck, and then a rigid scope is inserted along the length of the trachea to allow for dissection and resection of mediastinal lymph nodes. In 2004, we see the arrival of the convex probe endobronchial ultrasound, which would allow for performance of an ultrasound assessment of lymph nodes from within the airways, in addition to the ability to sample lymph nodes with imaging guidance. Dr. Yasufuku and colleagues in their early reports and experience demonstrated an ability to very effectively sample stations N1, N2, N3, while traditional mediastinoscopy is limited more to N2 and N3. In addition, they were able to visually assess lymph nodes based on size, shape, echogenicity, and of course perform biopsies with very high diagnostic sensitivity, specificity, and overall accuracy. And this less invasive option has largely replaced surgical mediastinoscopy as the primary mechanism for mediastinal staging for lung cancer. Techniques for diagnostic biopsies have also evolved dramatically over the last 2 decades. Electromagnetic navigation, which you can see pictured here on the left-hand side, is an image-based novel technology that uses the concept of virtual bronchoscopy and facilitates approaching peripheral lung lesions, which are difficult to assess otherwise and historically required a surgical biopsy. As navigation is performed, the operator of a bronchoscope can actually see a plethora of views and travel down to the nodule and perform biopsies. The technology has significantly improved diagnostic yield and expanded in patients in whom diagnosis of small nodules in particular could not previously been achieved. We've also seen more widespread use of pleuroscopy, and this procedure actually allows for inspection of the pleural space while allowing for a patient to be spontaneously breathing. The technique not only allows us to inspect the pleural space, but also perform biopsies, take down adhesions, and actually even perform a pleurodesis in some patients. But what about surgery? Certainly not to be left out. We've seen what I would call a minimally invasive revolution over the last 20 years, with so many groups working to find the optimal minimally invasive approach to treatment. Although we really kind of broadly classify things as open or minimally invasive, the reality is we have a smorgasbord of minimally invasive procedures, each with unique applications, benefits, and limitations. VATS, or video-assisted thoracoscopic surgery, was really the beginnings of this and the need to transition to a more minimally invasive approach for the management of thoracic disease and in particular lung cancer. And this is performed through 3 incisions, one serving as a camera port and the other 2 for the insertion of instruments, thereby achieving triangulation with respect to target anatomy. And since its birth, VATS has demonstrated that it can be safely performed and that there have been patient benefits such as reduced pain and enhanced recovery postoperatively. But adoption has been very slow, and even by 2010, we're seeing fewer than 30% of lobectomies being performed by this approach. And really, there are several reasons for that and the delayed adoption, and that was oncologic concerns and the lack of specialized instruments. And so over the last 10 years, we've seen significant advancements in technology, cameras, greater surgeon experience, and we've seen an additional emergence of new variations of the technique. An earlier alternative that emerged was actually the uniportal VATS option. And this is actually performed much like a VAT, so it's very minimally invasive. It uses a camera and specialized instruments, but it's performed through a single rib space. And the benefit of this approach is that having an incision in a single rib space, of course, means that we're going to have less pain. There's only one site where you might develop neurogenic pain. Of course, one of the downsides is you need more specialized instruments, which of course does come at a cost. Microlobectomy was developed out of a further desire to reduce perioperative pain and to simplify recovery pathways. Dr. Dunning, who really helped to develop this method, reduced his port size to 5 millimeters in between each rib to prevent any compression or injury to intercostal nerves. He also modified his technique for extracting specimens through a subxiphoid incision because the abdominal wall is considerably more pliable, and so you can actually pull a much larger specimen through a much smaller hole. And of course, this is a much less painful site to have a postoperative chest tube as well. So we're seeing a lot of these really incredible patient-centric modifications. Robotic surgery is another great option for patients. This one's very unique though, because unlike all the other mechanisms where the patient has the surgeon actually at bedside, the surgeon's not scrubbed into this case. We're actually at a separate console. And I remember early in my transition to robotic surgery, I was describing the surgery to one of my patients, and she looked at me and said, "If the robot can't get this thing done, are you going to come in and finish the job?" And I think her statement just so perfectly captures the mysticism and lore when we think about robotics. The technology is really incredible though, and it allows for the performance of pulmonary resections through very small incisions, 8 millimeters, and in some ways has managed to overcome some of the limitations of the other minimally invasive options. And so we have beautiful 3D high resolution images, enhanced degrees of freedom of the instruments, and they actually replicate the movements of our hands. Unfortunately, technology, just like all the others, does have some drawbacks. And in this case, it's haptics. We actually can't feel how hard we're pulling on things. I guess we just can't have it all. But despite not having the perfect approach, the breadth and complexity of minimally invasive procedures has continued to increase as surgeons have become more skilled with procedures. So why is this so important? Why does everybody trying to find a perfect way to do minimally invasive surgery? Well, it's because of the patients. It's better for the patients. We're seeing at least an equivalent oncologic outcome, and some data to suggest that it might actually even be better. We're seeing improved morbidity, shorter lengths of stay, and of course, we're also seeing less pain, which is a significant thing to think about for our patients. However, at the end of the day, regardless of the approach selected for the patient, there's a few overarching principles that must be accomplished. First is thoughtful selection of a patient, assuring adequate pulmonary function, adequate functional status to be able to tolerate a surgery. We must carefully select the order and combinations of therapies that are needed for our patients. Completeness of resection is of paramount importance, and minimizing morbidity. At the end of the day, the patient has to have a good resection, and so we should never, ever, ever sacrifice a good oncologic outcome in favor of smaller incisions. And so it's always important to choose the best option, the best incision for each of our patients.
Thank you, Dr. Das and Dr. Gillaspie. And now I will have Dr. Keane talk to us about all of the possible radiation options for this patient, if that's appropriate.
Thank you so much, Dr. Kazmi. So for this patient, as we know, we're going to talk about the role of radiation. And the role of radiation, shifts as patients have more advanced disease. This is a patient, obviously, with N1 disease, but we're going to talk about the role of postoperative radiation therapy here in general. Now, we know that even after an optimal surgery, there is still a risk of local failure in the mediastinum, and that depends on multiple factors, including preoperative staging, the number of lymph nodes involved, whether there's extracapsular extension, as well as patients' response to chemotherapy. And local failure can certainly impact patients' risks of distant failure as well as their overall outcomes. Now, postoperative radiation therapy has long been recommended for patients with N2 involved lymph nodes, and this data was largely based on retrospective and large database series. So we can see here a SEER analysis, a subgroup of the ANITA trial, and an NCDB study all showed a benefit specifically for patients with N2 disease. However, we also know that postoperative radiation therapy can be associated with risks, particularly when we're treating large treatment fields. And this is something that really has been emphasized more and more in studies over the past 5 years, where you can see that some of the survival gains from postoperative radiation can be offset if patients have higher risk of toxicity. And we certainly saw this in the PORT meta-analysis, where there was not a benefit in patients who did not have N2 disease. As I mentioned, the historical radiation fields were quite large, and the techniques of 3D radiation require treatment of significant areas of uninvolved tissue. In this patient here, you can see that we're exposing a significant volume of the heart as well as the remaining lung to the radiation. Now, with modern radiation therapy techniques, VMAT and IMRT, we're really able to better deliver highly conformal focused radiation, so delivering an effective dose to the area that needs to be targeted, while protecting and avoiding the normal healthy tissues nearby. As you can see here in this patient, we have the dose basically carving nicely around the heart, really minimizing the exposure to radiation. Now, we also now finally have randomized data for this question, and this is the LongArt trial, which was presented at ESMO earlier this year. This was a randomized trial looking at the role of postoperative radiation therapy in patients with N2 disease. 500 patients were included, and it's important to note in terms of the exclusion criteria with these patients that they did not allow patients who had an R1 resection or extranodal extension. So these were all patients with completely resected tumors and N2 disease, as I mentioned. And the disease-free survival, as we see, which was the primary endpoint of the trial at 3 years, there was not an improvement with the use of postoperative radiation. As you can see, these curves really parallel each other here, and there was no benefit with a p-value of 0.16. Similarly, with overall survival rates at 3 years, there was no benefit with the use of postoperative radiation therapy. Now, when we delve a little bit more into the data, we do see that in terms of the risk of mediastinal relapse, there was a significant reduction in this with postoperative radiation. The concern, though, is that this is being offset by toxicity. In the postoperative treatment arm, there were 11 cardiopulmonary deaths. And so that does raise concern as to whether that benefit is then offset by the potential side effects of radiation. When we delve into this a little bit more, we are seeing that these risks of cardiopulmonary toxicity and second cancers certainly are outweighing some of the benefit of postoperative radiation in this population. Now, why is this happening? It is important to note that with the lung ART trial, 90% of the patients were treated with the older technique of 3D conformal radiation therapy, which does, as I mentioned, require exposure of larger volumes of normal tissue to the radiation fields. The targets were also quite large. So this was not just focused on the hilum and the involved N2 station. They required, in most cases, treatment of a station above and below, which obviously also increases the field size. As we can see here, this translated into higher mean heart doses, which we know is an important metric, over 13 Gray, which is quite high. And as I mentioned, we see here that 90% of patients received 3D radiation. So the question is, should we still consider postoperative radiation on a case-by-case basis? I think, we certainly need to wait for the lung ART trial. I think it's important to assess each patient in a multidisciplinary setting. Certainly talking with our pathologist to ensure that there's been a complete resection and that there's no extranodal extension is critical. And really, it's a careful assessment of the patient's risk of mediastinal failure as opposed to their risk of distant failure. And typically the way that we're considering this at our institution is really looking at each patient individually in terms of the extent of N2 disease, the risk of other sites, and really with an emphasis on that if you are treating these patients, for example, a patient with extranodal extension, that the target really needs to be very focused and conformal and using modern techniques. For this patient here, certainly as she has N1 disease, we would not recommend postoperative radiation. And certainly with N2 disease, if she were to have N2 disease with the EGFR mutation, I would also favor really avoiding postoperative radiation for her, given that I would say her priority should be Osimertinib.
Thank you so much, Dr. Keane. So really, prior to going to case 2, we'll just summarize that with this young lady with T2N1 disease that was fully resected, she definitely qualifies for adjuvant chemotherapy, platinum-based chemotherapy, which was allowed in the ADAURA trial, and up to, I think, 30% of patients did receive adjuvant chemotherapy. Thereafter, there is no role for radiation therapy, at least in this patient with N1 disease. And even if she were to be N2, I think we would have to debate whether the utility is worth it in her case. And then 3 years of Osimertinib, though not fully approved yet, would be what's recommended based on the current data. So I think that's a good conclusion. There are lots of questions about ongoing use of Osimertinib. What do we do when she relapses? Certainly we don't have answers for those. We don't have a 4th generation TKI at present, but those questions remain to be answered. But in the interest of time, we're gonna move on to case 2, metastatic squamous cell carcinoma patient. So this is a 64-year-old smoking male, presents to his PCP for routine evaluation. He's up to date with his colonoscopy screening. He's even getting PSA screenings. Those are certainly debatable. And given that he's an active smoker with 35-pack-year smoking history, the primary care physician sends him for a screening lung CT. It's interesting to note that of all the eligible patients in the country who may be able to be screened with lung CT, about 3 to 5% of the patients in the United States get these. So they're certainly very underutilized, and we'll discuss that data as well. Unfortunately, even though he was asymptomatic, the CAT scan shows a large right upper lobe cavitary mass with significant local adenopathy, airway obstruction, and post-obstructive pneumonia. There's a small incidental T4 sclerotic lesion as well, consistent with metastases. Patient does undergo CT-guided biopsy of the lung mass, and it's consistent with the squamous cell carcinoma of lung origin. The PET shows uptake in that mass, mediastinal and hilar lymph nodes, and the T4 lesion. The brain MRI is negative for any cranial mets. The PD-L1 is tested at 70%. Past medical history, hypertension, coronary artery disease, and mild BPH. Social history, patient is divorced. He does smoke 1 to 2 packs a day for 40 years and rare alcohol. So the questions in this case, certainly as we pointed out, is really discuss the role of lung cancer screening. It's really underutilized in the United States. discuss the role of radiotherapy for obstructive large volume disease with one metastatic site. Certainly patient has M1 disease, and whether there's any role if there's going to be imminent obstruction or if there already is obstruction. And discuss the utility of next generation sequencing in squamous cancers and where do we stand today. And then of course, the first line systemic therapy, in this case, IO alone, IO combination, or chemo IO, and how do we choose these?
Dr. Kazmi, thank you so much. I'm so pleased to talk a little bit about lung cancer screening. So as we all know, unfortunately, the majority of patients with lung cancer present at later stages of disease. And while we have a dramatic expansion in our treatment options for later stages of disease, thanks to some of my incredible colleagues up here, we'd still ideally like to identify these patients at an earlier stage if possible. And that's because we know that survival is enhanced by an earlier stage of diagnosis. So screening tests are created with a couple of goals. First is detecting a cancer prior to the presentation of symptoms, ideally at an early stage to enhance treatability. Early efforts at developing lung cancer screening really were focused principally on chest x-rays and sputum sampling. And unfortunately, these were largely unsuccessful because they had no change in the rate of lung cancer death in studies. However, technological advancements, and in particular, the advent of the low-dose CT scan, made this a really attractive option to consider for our patients. Really, the landmark trial evaluating the use of low-dose CT scan is the NLST. This is a multi-center randomized controlled trial performed in the US that compared an annual chest x-ray to a low-dose CT scan in 53,454 patients who were considered high risk. Actually, the study was terminated early when it met its primary endpoint of achieving a 20% relative reduction in lung cancer mortality, favoring the low-dose CT arm. Some of the key take-home points in this study were that the low-dose CT scan not only achieved this 20% reduction in lung cancer mortality for this high-risk group, but nearly twice as many cancers were detected at an early stage compared with the chest x-ray group. They found that 320 people must be screened to prevent one lung cancer death. And this actually compares really favorably to other types of screening. So for example, breast requires a screening of 1,339 patients to be able to prevent one breast cancer death. So really comparing very favorably with regards to a screening modality. A number of additional trials have been performed, but really only the last two were adequately sized to detect a difference in lung cancer mortality. And so in addition to the NLST, which we just talked about, there's the Danish-Belgium lung cancer screening trial as well. That goes by Nelson for short. And this study actually detected even a better reduction in lung cancer mortality, a 26% relative reduction when screening high-risk individuals with a low-dose CT scan compared with no screening, further supporting the role of incorporating low-dose CT screens in high-risk individuals. The application of screening requires a lot of team members to participate. So we need radiologists, we need clinicians, and this can be a pulmonologist or a medical oncologist, as well as coordinators who are going to help to organize scans, communicate results, and of course, coordinate additional testing as needed. Because approximately 25% of patients will have some kind of a finding on their scan that may require additional imaging, could require procedure as well to help determine if their findings are benign or malignant. There are, of course, some risks associated with screening. Of course, the most common criticism that we hear is the false positives. So we find a nodule that's not cancer. And in some cases, this does require additional imaging or testing. So it's additional things that an additional cost that can be incurred. But there's also the risk of a false negative, meaning that a cancer is missed. However, with the development of screening, we've also seen this concomitant development of lung RADs. And while I'm not going to go into all of this in detail, the American College of Radiology has created this really extraordinary structured reporting system that has facilitated a further decrease in the false positive rate by creating a really sophisticated evaluation reporting system. It's now gone through several iterations and has really enhanced the standardization of screening reporting. It offers clear management recommendations and facilitates outcome monitoring. So who should we be screening? Well, the USPSTF, based on a meta-analysis looking at the results of all available studies, have recommended screening patients between the ages of 55 and 80 who are current or former smokers with at least a 30-pack year history, so a pack a day for 30 years or 2 packs a day for 15 years, who've quit within the last 15 years and have no symptoms of lung cancer. So this patient, perfect candidate.
Thank you, Dr. Kazmi. So I'm going to talk about the role of radiation for this patient. So radiation plays a critical role in the management of patients with metastatic lung cancer. Over half of patients will receive radiation therapy at some time during their treatment course. And radiation can be used in multiple ways. It can be used for palliation, but intriguingly, and more now, it can also be used to treat sites of oligometastatic disease with the goal of keeping a patient on otherwise successful systemic therapy, contribute to maximum or cytoreduction, and to potentially synergize with systemic therapies. Now, to first address his obstructive symptoms, so we know that local disease can have a significant impact on patient quality of life and outcomes. And this is due to the potential of all these side effects that can be caused. So there can be bronchial obstruction and lobar collapse, shortness of breath, bleeding, chest pain. And this Kaplan-Meier curve is from a study that looked at patients enrolled on first-line trials of chemotherapy and showed really the difference in outcomes just based on whether patients had bronchial or vascular compression at time of diagnosis. So a difference in median survival in this population of patients. And in general, radiation has excellent response rates here. Patients have about a 70 to 80% response rate for both airway obstruction and hemoptysis. And so this can be a very effective treatment option for these patients. Now, the other intriguing way that we think of radiation in this setting is what is the role of SBRT or ablative radiotherapy? And I think when we're thinking about patients with stage 4 disease, we can break this down into sort of 3 groups, and this is setting aside those patients who need palliation. There's patients with oligoprogression. So this is a patient who's on systemic therapy, who has one site of disease that is progressing, but otherwise has very well controlled cancer. Oligometastatic disease, which, as I'll discuss, the definition of is in somewhat flux. And then synergy, potentially with immunotherapy. Now, just to give a brief definition, when we talk about stereotactic radiosurgery, SRS, or stereotactic body radiation therapy, SBRT, what we're talking about is high dose radiation that's delivered in just 1 to 5 treatments or fractions. And by delivering the dose at this rate, we're delivering basically an ablative effect in addition to the normal way that radiation functions. And this, for example, is a patient with a spinal tumor receiving SRS to a vertebral body. And as you can see with this, we can deliver a very high dose to the tumor while carving out and making sure that we're sparing the spinal cord, which has a very specific sensitivity to the radiation. Now, what is oligometastatic disease? So traditionally, this was defined as solitary brain or adrenal metastasis that could be resected. The definition has certainly broadened with improvements in systemic therapy and improvements with radiation treatment delivery techniques. Recent consensus group published recommendations suggested a maximum of 5 metastases and 3 organs, but obviously there's a lot of controversy and ongoing debate, and randomized trials have allowed a range of patients to enroll. When we look at some of the studies that have been published, as we can see here, the numbers are somewhat low, typically, 99 patients in the largest trial thus far. And the consolidative therapies in general have varied, but most recently are predominantly SBRT or hypofractionated radiation. Now, as you'd expect, when you're treating every site of visible disease with a local therapy, we see an improvement in progression-free survival, which you would hope to see if you're treating every site of disease that you're aware of. But what is, I think, particularly encouraging and what's really increasing interest in this is as we see longer follow-up, we're also seeing an overall survival benefit in these patients. Now, doing SBRT for oligometastatic disease is not without risk. There are adverse events in these patients, and so patients really do need to be very carefully selected to make sure that they will actually benefit from aggressive local therapy. And as you can see here, just one other point, in terms of the number of metastases of patients enrolled, as you can see, it varies. Most of these trials had patients with 1 to 2 metastases, so really we do need more data on patients with 3, 4, or even higher numbers of metastases receiving aggressive local therapy. Now, in patients with oncogenic driver mutations, there's also increasing data on the use of SBRT for these patients. This was a study looking at patients with EGFR mutant non-small cell lung cancer who received their TKI with or without SBRT. And this did translate to an improvement in progression-free survival. The next question is just the potential interaction of radiation and immunotherapy. And I'll point to one sort of very intriguing study here. This was the Pembro-RT trial, which was a phase 2 randomized trial of SBRT followed by Pembro versus Pembro alone in patients who had progressed past one line of systemic therapy. Now, they were randomized to SBRT followed by Pembro versus Pembro alone. And what's important to note is the patients were not stratified by PD-L1, which is obviously an important thing for us to consider. The overall response rate did show a trend towards improvement in those patients receiving SBRT, but what's particularly encouraging and intriguing is in the PD-L1 0% cohort, you really had a significant improvement in the response rates in those patients who received SBRT in addition to Pembro, suggesting that perhaps there is a potential for synergy here in converting an immunologically cold tumor into one that might respond to immunotherapy. Certainly, we need more trials to assess this, and randomized trials are ongoing. But I think the important take-home points are that both conventionally fractionated radiation and stereotactic radiation can play a significant role in the management of patients with metastatic cancer. We have increasing data for the use of SBRT, particularly in oligoprogressive or oligometastatic patients. And what I would say is most important is that patient selection and a multidisciplinary assessment is key to determining which patients will most benefit from aggressive local therapies.
Thank you so much, Dr. Keane. So this patient certainly may fit the criteria of the oligometastatic disease and the obstructive lesion, as well as the T4 solitary MET. And that's something that may be an option for this patient as well. So I'm going to talk a little bit about the role of next generation sequencing in squamous cell lung carcinomas. We know that lung cancers are really in the forefront of precision medicine, but primarily those are the non-squam, non-small cell lung cancers, and typically the adenocarcinomas. The squamous histotypes, actually this is my first slide. So this disease is found mainly in smokers and carries a high burden of mutations. The difficulty in all of this is identifying the actual mutation that might be the driver and may be clinically relevant, because there's a lot of noise with these mutations. Now, we know that genetic alterations are typically found with various techniques, IHC, FISH, and NGS, though in most of metastatic malignancies and lung cancer specifically, NGS is the preferred modality. It is very, very comprehensive. For adenocarcinomas, we know that the most common therapeutic targets are EGFR and BRAF mutations, ALK and ROS1 rearrangements, with others such as MET, RET, NTRK, and HER2 showing various degrees of response in clinical trials. We know that the squamous histotypes arising in many different anatomical sites feature this genomic pattern of squamousness, and these frequent mutations include TP53, PIK3CA, PDKN2A, SOX2, and CCND1. One example of really a mutation that cannot be targeted easily, SOX2, is a transcription factor, the predominant downstream target of the EGFR signaling pathway, and has a role in self-renewal, growth, and expansion of cell populations. But because of lack of small molecule binding pockets, it's really an undruggable target. We know that currently the first line of treatment, and Dr. Das will really get into specifically with this patient, is platinum-based chemotherapy doublet or immunotherapy or a combination thereof. Second line, we treat these patients with immunotherapy if they haven't already had these, or if we're going to do chemotherapy, we can add anti-angiogenic or anti-EGFR tyrosine kinase inhibitors, but the latter two really have marginal clinical impact. So a recent publication from the LUX-Lung-8 trial that used NGS to identify whether ERBB gene alterations derive an increased benefit from anti-EGFR TKI afatinib compared to erlotinib. There were many study-related flaws, which we're not going to get into, though they did see that 26% had ERBB2 family mutations, actually not just ERBB2, it's 1, 2, and 3, and there was a trend of increased overall survival in favor of afatinib. So this is interesting. Some of the other potentially actionable genetic alterations may be FGFR1, amplification in 20% of patients with squamous cell cancers. Now, there is better prognosis in patients who have FGFR1 mutations. However, in a small trial, there was no survival benefit noted. This was the LUM-Lung-1 trial in adding an FGFR inhibitor, nintedanib, to docetaxel in second-line therapy. So we don't know yet the role. There are larger international studies still pending. PI3 kinase is a missense mutation. There could be an amplification. This occurs in about 20% of patients with advanced squamous cell carcinomas, frequently associated with loss of PTEN. Unfortunately, beparlizumab showed poor disease response with only 20% PFS at 12 weeks in these patients with PIK3CA activating mutations. So it does not seem to be a driver mutation in these cancers. The MET signaling pathway is often dysregulated in solid malignancies, and MET overexpression has been reported in 29% of squam patients, and it is associated with poor prognosis. However, in cancers driven by these MET amplifications and overexpressions, the downstream signaling is unlikely to be fully blocked by these drugs that target solely the HGF MET binding. Another potential option for target could be this DDR2 gene mutation, and it's found in only 4% of squamous cell carcinomas, but there is some early sensitivity to dasatinib. So really, in conclusion, we have ways to go. The Lung MAP is a collaborative international study comprising of multiple phase 2 studies, each for a specific biomarker identified in squamous cell carcinomas. It's been designed to provide a path for FDA approval for active agents identified in initial phase 2 studies. And hopefully this master protocol may improve access to genomic screening for these patients, improve the identification of genomic biomarkers for clinical trial entry, and perhaps accelerate drug biomarker testing.
Okay, so I'm going to just end here with talking about first-line systemic therapy options for patients with metastatic squamous cell carcinoma. And of course, Shayma sort of alluded to the potential options of either immunotherapy alone or immunotherapy combinations or chemo IO, and how do we choose between the various recommendations. So I wanted to just, again, start with the NCCN guidelines, which many of us in practice are going to be following when we're seeing a patient in front of us and talking about systemic therapy options. So for squamous cell good performance status patients, you can see that the preferred regimens are listed here. So pembrolizumab, which is a PD-1 antibody in combination with carboplatin paclitaxel, is a category 1 recommendation. Pembrolizumab with carboplatin and albumin-bound or nab-paclitaxel, also a category 1 recommendation. Other recommendations are the combination of nivolumab and ipilimumab. So nivolumab is a PD-1 antibody in combination with the CTLA-4 antibody ipilimumab, and lastly here, it's the nivo-ipi plus carboplatin paclitaxel combination. So I'm going to go through some of the data that supports these recommendations. For those patients who can't get immunotherapy for whatever reason, typically these are patients who you're concerned that they have an underlying autoimmune disease that would flare with initiation of immunotherapy. You can consider a whole host of other chemotherapy, cytotoxic chemotherapy regimens without the addition of immunotherapy. And those are listed here. So I'm going to start with the Keynote 407 trial. So this was a randomized phase 3 trial involving patients with metastatic squamous carcinoma, randomizing them to receive either standard chemotherapy with either carboplatin paclitaxel or carboplatin nab-paclitaxel, or this chemotherapy plus the addition of pembrolizumab. And what the study found was that those patients getting the addition of pembrolizumab actually did better. They had a better overall survival hazard ratio of 0.71, which was statistically significant. Progression-free survival also favored those patients getting the addition of pembrolizumab. Overall response rate really did favor those patients getting the addition of pembro, 63% versus about 38% in those patients getting chemo alone. And what we saw was that the benefits were seen really regardless of PD-L1 status. So even those patients who did not have PD-L1 expression seemed to benefit with the addition of pembrolizumab. So this was really the major trial that led, to FDA approval and to the NCCN guidelines. And this is really what, being modified. And this is really what most of us in clinical practice are using for our patients with metastatic squamous cell carcinoma. Next came the nivo-ipi data. So this is the Checkmate 227 study. So this was, again, involved metastatic squamous cell patients. So this was the Checkmate 227 study. So this was a study that actually included both squamous and non-squamous histologies, but patients were stratified based upon histology. Again, these are advanced stage patients, no prior systemic therapy, no known sensitizing EGFR or ALK alterations, good performance status. Patients were randomized in somewhat of a complex schema. So they based it upon PD-L1 expression. So those patients who had greater than or equal to 1% PD-L1 were randomized to one of 3 different treatment arms, either the combination of nivo-ipi, standard chemotherapy. So for the squamous patients, here they got carboplatin paclitaxel, Or the third arm here was just Nivo alone. For those patients who did not have any PD-L1 expression, so less than 1%, the 3 treatment arms were a little bit different. So again, it's the Nivo-Ipi arm, chemotherapy, and then here instead of Nivo alone, it was Nivo plus chemotherapy. And again, it was the carbotaxol regimen for our patients with squamous histology. And this is the Kaplan-Meier curve depicting overall survival in those patients with PD-L1 expression levels of greater than or equal to 1%. So this was really one of the primary endpoints of the trial. And what you can see here is that there is separation of the curves favoring those patients getting the combination of nivolumab and ipilimumab. Overall survival hazard ratio is 0.79, which is statistically significant. So this was actually published in the New England Journal fairly recently and and this publication led to FDA approval of the combination of nivolumab and ipilimumab in non-small cell lung cancer in those patients with greater than or equal to 1% PD-L1 expression. And just to note, it did include patients with squamous histology. We also see that the combination of Nivo-Ipi has potential for prolonged duration of response, again, regardless of PD-L1 expression. So looking at the patients with greater than or equal to 1%. Okay, so what you can see here is that the overall response rate with the Nivo-Ipi combination was 36% with a median duration of response of close to 2 years, which is pretty remarkable. And we're seeing sort of similar results in the PD-L1 negative group. Overall response rates, 27%, duration of response, 18 months. So what's really exciting about immunotherapy in general is just the possibility of these, of patients having long-term responses to these drugs. So this is just a forest plot looking at the risk of death in the pre-specified subgroups. And again, I just wanted to point out the squamous histology because that's really the focus of this case presentation. It does appear that those patients with squamous histology did do better with the combination of Nivo-Ipi compared to chemotherapy, and the hazard ratio here was 0.69, specifically for the squamous group. Also, again, just to show that we're seeing the benefit of Nivo-Ipi over chemo regardless of PD-L1 expression levels and regardless of TMB. So tumor mutation burden is another biomarker that many are looking at as far as predicting response to the immunotherapies. And again, we're seeing response regardless of. And then moving on now to the addition of limited chemo plus Nivo-Ipi in the frontline setting. This is the Checkmate 9 LA study. So this was actually presented at ASCO this year. And again, this involved patients with all histologies of non-small cell lung cancer, but patients were stratified based upon squamous versus non-squamous histology, no prior systemic therapy, no known EGFR or ALK alterations, good performance status. Patients were randomized 1-to-1 to either nivolumab plus ipilimumab. So the Nivo here was given at a dose of 360 mg every 3 weeks, plus Ipi 1 mg per kg every 6 weeks, plus chemotherapy. Again, those patients getting with squamous histology got carboplatin paclitaxel given every 3 weeks. The other treatment arm was just a standard treatment arm of chemotherapy given IV every 3 weeks. And patients received treatment until disease progression, unacceptable toxicity, or for 2 years for immunotherapy. And the primary endpoint here was overall survival. And what you can see here is that the Nivo-Ipi plus limited chemo, those 2 cycles of chemo with Nivo-Ipi, that treatment arm did appear to show a survival benefit over chemo alone at the interim analysis. And the updated hazard ratio that we're seeing is a hazard ratio of 0.66, which was statistically significant. And this was a follow-up of a little over a year. So clear separation of the curves, really favoring that sort of limited chemo plus Nivo-Ipi as compared to the chemo alone arm. We also see from these curves here that Nivo-Ipi plus limited chemo improves survival over chemo alone, regardless of PD-L1 status. So that seems to be just a recurring theme, is we're seeing benefits of immunotherapy regardless of PD-L1 expression. And that was seen again in this trial. And then I wanted to also just point out that, we do look at PD-L1 expression to really decide what best treatment option to offer our patient, and particularly those patients who have what's known as high PD-L1 expression, and that's defined as greater than or equal to 50%. We also have the addition of two other treatment options, namely pembrolizumab given as a single agent or atezolizumab given as a single agent. And you may be familiar with this data. So this was the Keynote-024 5-year follow-up. So this was a study involving patients with high PD-L1 expression, again, greater than or equal to 50%, randomizing these patients to getting either pembrolizumab, single agent versus standard chemotherapy. And what the study found was that those patients getting pembrolizumab did better. And this is the 5-year follow-up, again, showing consistent improvements in those patients getting pembrolizumab, clear separation of the curves even at 5 years. Hazard ratio here is 0.62. The atezolizumab data is a little bit more recent. So this was the schema for the Empower 110 trial. So this was a study that selected patients based upon PD-L1 expression. So only patients who had some degree of PD-L1 expression were included in this trial. And again, patients with non-squamous and squamous histology were included here. The stratification factors are listed here and included histology, and patients were randomized 1-to-1 to either atezolizumab, which is a PD-L1 antibody, single agent versus chemotherapy. And for our squamous patients here, the patients received platinum gemcitabine. And what you can see is that in the high PD-L1 expressors, those patients who got atezolizumab did better as compared to those patients who got chemotherapy. And so this is also now, atezolizumab is also now approved as a single agent frontline option for patients with high PD-L1 expression based upon this data. So just to summarize, I think that there are a number of different options for our patients with squamous histology. So particularly for our high expressors, this is where really we have kind of the most options. So we have data to support the use of single agent pembro or atezolizumab. And we also know, of course, that chemotherapy plus immunotherapy is quite effective. I would say in my patients who have high PD-L1 expression, who have a high tumor burden, where they're symptomatic and you want to get them out of trouble quickly, I would talk to them about adding chemotherapy. Of course, we know that we can use single agent immunotherapy. The concern is that we're just not going to get a response quickly enough to get these patients feeling better. And so if for a patient who's otherwise fit to be able to receive chemotherapy, I'll go ahead and offer that patient chemotherapy plus immunotherapy. For the patients with a PD-L1 expression level between 1 and 49%, combination chemo plus IO is really the standard. Sometimes single agent immunotherapy, I just mentioned that because it's in the NCCN guidelines where we do have an approval for pembrolizumab alone. This is a category 2B recommendation. It's really more for those patients with poor performance status, patients who really can't tolerate chemotherapy for whatever reason. And I went through the sort of the keynote data with the carboplatin, either nab-paclitaxel or paclitaxel with pembrolizumab, and that's kind of what most of us are using in clinical practice, just because we have more familiarity with this regimen in terms of it just being around and FDA approved for a longer period of time. Although we have this newer data with Nivo/Ipi plus or minus chemotherapy, we just don't have as much long-term data here, but these are approved regimens and they can be used in this setting. And then those patients who don't have any PD-L1 expression, again, really good data to support the combination of chemotherapy plus immunotherapy. We know that the immunotherapy, still works in this patient population. And again, most of us are, using the platinum with taxane and the addition of pembrolizumab for these patients. Again, we still have the option of Nivo/Ipi plus or minus chemotherapy. As we're getting more data and I think we're going to get longer term follow-up, I think we may be shifting more to that regimen, though I think most of us are still using the platinum taxane pembro. And that's what I would offer to this particular patient in our case.
Thank you so much, doctors. This was a really, really informative section, really exhaustive in terms of, we started with the lung cancer screening data, which was really helpful. And this patient unfortunately got diagnosed at a screening CT and perhaps would have been much later stage if he didn't have that, although he was quite advanced at diagnosis. But given the oligometastatic disease, he has multiple radiation options. He has immunotherapy options, as Dr. Das outlined, certainly single agent immunotherapy, perhaps combination because of the obstructive symptoms. Perhaps could be a candidate for the Nivo/Ipi if he's not really interested in chemotherapy. No one really knows the best option here because, as we mentioned, there's no head-to-head comparison. It really ought to be patient-specific. So I would just like to conclude with what a fantastic presentation. Certainly we touched on a lot of very, very important topics, and we're realizing more and more that an hour is hardly enough to discuss all of the nuances of the various surgical diagnostic and surgical resection techniques that have advanced, the radiation techniques, both in the curative patient as well as in the palliative patient with different radiation techniques as well. And certainly in medical oncology, there are many, many treatment options for patients when it used to be just chemotherapy, and now immunotherapy is certainly very much a mainstay. And now that we're getting really into genomic sequencing and really getting targeted treatment options for patients, the world of lung cancer has really, really expanded. Great for patients, really complicated for physicians and colleagues to stay abreast of a lot of this data. So thank you for joining us, and I'd love for the rest of the team to have some closing words. How about Dr. Gillaspie? Can you give us a few insights?
Sure, absolutely. Thank you again to just this incredible panel of colleagues that I have the privilege of speaking with today. I think, screening is so important. It is very difficult. It requires really dedicated teams. I'm so grateful to my team that does it, but it's so important. We need to look for more ways to screen our patients. One of the things I always tell people is screen the spouse. If you're screening your own patient, make sure if the spouse is in the room, grab them too. Screen everybody you can if they meet the criteria for it. There's a lot of really different ways to do surgeries. There's, minimally invasive, of course, and open. At the end of the day, it's really important that our patients get a great oncologic surgery. So they need the whole tumor resected. We need good margins. We need a robust lymphadenectomy, a lot of sampling of lymph nodes to give the best possible outcome. More than anything, it's a wonderful field where we get to collaborate with so many fantastic colleagues. And so thank you guys for allowing me to be here this evening.
Dr. Keane?
Thank you. I would just like to echo Dr. Gillaspie and you, Dr. Kazmi and Dr. Das. It's been great to talk with everyone, and we're so appreciative of everyone sort of tuning in as we go through these cases. But I think, I would echo the importance of just multidisciplinary discussion and evaluation of patients, particularly as the role of local treatments is expanding in patients with metastatic disease. I think this is really an area where careful selection can really benefit our patients, particularly as the radiation techniques have evolved. To really increase the effectiveness of treatment while minimizing the potential side effects. And I think this is a really exciting area where hopefully we'll see patients continue to improve in combination with all these advances in systemic therapy over the next few years.
Thank you. And Dr. Das?
Yeah, it's been really exciting to be on this panel and to be able to speak to all of you about lung cancer, because I just think that this is a really revolutionary time in cancer treatment in general, and lung cancer in particular. I think a lot of us are reading in the news the sort of cancer-related deaths declining, and in large part due to the advances in lung cancer associated with screening and associated with our better therapies. And I just think it's fantastic to be able to, get so many new drug approvals on a really frequent basis in lung cancer. It is really difficult to stay on top of, but it's really just expanding our treatment options for our patients. And, being able to talk to patients about, treatment options now, and then letting them know that, these are kind of the options now, but that can change in 6 months when we need to change therapy. And so I think it's not static. It's very much an evolving treatment paradigm, and I think it's very exciting to be part of the treatment team for these patients.
Thank you. Thank you to a fantastic panel. What a great bit of information we have. And remember that this is a women's conference, and I'm so glad that they're not forgetting that, lung cancer is still the #1 killer of cancer in women. It may be the third in incidence. So really, really thank you, all of you, for having us. And thanks, Dr. Keane, Dr. Gillaspie, Dr. Das, for a fantastic panel. Have a good day.